good if I spend the first 10 minutes of the talk showing you some of the interesting cases I saw this year. And I'll use these cases to highlight the important points I want to make about red flags, about there's when to worry about migraine for 5 minutes. And then the last 5 minutes, I'll talk about when to image and what imaging modality to use. So case one, this very interesting 50-year-old Indian man that presented with episodic headache at multiple sites for many years, and usually frontal hospital, and also frequent frontal hospital headaches for a few weeks. They were moderate intensity, non-throbbing, not aggravated by head movement, no nausea, vomiting, blah, blah, blah. So he has the picture of tension headaches. And he also gave a history of long-standing sinus problem described as cold, lasting 1 to 2 days each time. And he denied any mucopurulent discharge or hyperosmia that made impairment of smell. So neuro exam was normal, but it prompted me to do an MRI scan for him because I don't like the part about this nose problem. So anyway, so the MRI showed actually thickening and inflammatory changes in the maxillary sinus and also on one side of the sphenoid sinuses. So I sent him to the ENT. And what they found was that they did a scope and they found significant mucopus in the right meatus. And the ENT surgeon thinks that the patient tended to downplay most of the symptoms of sinusitis and treated with antibiotics and nasal nacs. So the take-home message is this, better don't touch this. Patient with migraine can present with sinus pain, and patient with acute bacterial sinusitis can present with headaches that looks a bit like tension headache or migrainous type of headaches. The way to differentiate the two is that bacterial sinusitis usually come with fever and purulent nasal discharges, whereas migraine, if they cause sinus problem, usually it is a white mucoid discharge. So you must be able to differentiate between the two because the treatment is totally different. The next case is a 67-year-old Chinese lady. This very interesting case referred by GP. I think the patient is the mother of his clinic assistant. I'm not sure the GP is here. And this patient complained of seeing green color pattern of a flower over her right eye twice every week for 2 months. And no matter how I asked her to describe further, that's why she keeps saying green color in the pattern of a flower over the right eye. And usually followed by pain in the right eye and right-sided headaches. But during the last 2 attacks, she experienced blurring of vision of the right eye, and they lasted for about 30 minutes each time. She was seen by an ophthalmologist early on and was told it was normal. And she has a history of treated hyperlipidemia. So given the age and hyperlipidemia and normal neural exam, I was actually more worried about amaurosis field gap because I'm a stroke neurologist also. And the MRI here, the MRI angiography of the circle of Willis was normal, 2-breast carotid ultrasound was normal, and the ECG was also normal. So while waiting to see me for review after the investigation, she had another episode of this green-colored flower on the right side. So she went to see the ED, another hospital, and the ophthalmologist saw her there and found that she had raised intraocular pressure of her right eye and diagnosed acute glaucoma and was treated with eye drop and laser, and then she had no more visual symptoms and headaches. So the take-home message is that we can actually suspect acute glaucoma from the history because usually they will see halos around the light bulbs and they may see rainbows color around the bright light bulb. And I think it's occurs probably because the cornea is edematous and it affects the refraction of the lights. And of course, there are changes during the acute attack. There will be conjunctival injection, there will be clouding of lens, nausea, and vomiting. At the time when I saw her, of course, it was in between attacks, so she don't have any of these symptoms and signs. So, yeah, don't miss acute glaucoma for acute migraine headaches. And this is the IHS definition of glaucoma. And then the third case, a 28-year-old Chinese lady presented with bitemporal, gradual onset, severe intensity throbbing headache for about 5 days. So quite an acute onset headaches. And it was worse on sitting up and better on lying down. And she was vomiting for 2 days. On top of that, she gave a history of URTI with fever about 10 days ago, and it's associated with frequent history of sinusitis. And there was no injury to her head or to her back, and the neural exam was normal. And she got admitted by A&E because of the short history and this worry about meningitis because of the fever and the URTI. And we scanned her head. The CT was normal. We went to MRI, and MRI showed enhancement of the dura. Not this one. This one is the venous sinus. This is the layer of dura, and you can see that the dura is enhanced. And this is, of course, suggestive of intracranial hypotension. And we did a lumbar puncture. The open pressure was low, and the chemistry was normal, and the headache improved with bed rest and hydration. This condition, of course, is a telltale symptom. That is, it is precipitated by standing or sitting up. Within a few minutes of standing up, you get a booming headache, and within a few minutes of lying down, the headache goes away. So what happens is that when there's intracranial hypotension, right, there will be a sagging of the brain, and this sagging of the brain will, of course, stretch the meninges and the brain structure, and this will trigger off the pain receptors. And when they lie down, of course, the pressure is released, and the headache will go away. And most of the time, it happens because of some trauma to the back that they cannot remember. Treatment usually with hydration and rest. Bad cases, we have to do a dural blood patch. We take some blood from the patient and shoot it epidurally so that the clot will close up the hole in the meninges. The fourth case is a 29-year-old Chinese man who presented with very severe intensity, non-throbbing frontal headaches once every 2 months for the past 6 months. And it was precipitated by getting up from the sitting position, and the headache preceded by seeing mosaic-like pattern in the right visual field for up to about 1 hour. Again, I asked him to describe more about this mosaic thing, whether it's bright shimmering lights, and then he said, no, it's like a mosaic pattern, you see. So I presume the mosaic at home has a shimmering pattern too. And anyway, he was associated with vomiting, aggravated by head movement, has photophobia and phonophobia. So to me, it sounded a bit like migraine. And then neural exam was quite normal, except that he had some inconsistent visual field defect at the extreme end, bitemporal. Sometimes yes, sometimes no. And this prompted me to do a scan, not just because of the visual field, but because I thought it's a bit unusual for a patient with migraine to get a headache precipitated by getting up, and then sort of relieved by sitting down. So I went on to do the MRI straight for the patients, and lo and behold, the imaging department called me up straight away. He had a huge pituitary macroadenoma. There sort of, you can see that he had displaced the optic chiasma out of the way. Despite that, the visual field was not too bad. It shows that the brain has a lot of. We did the serum prolactin was sky high, 42,000 milli international unit per liter, and this is the highest that I've ever seen. So I quickly referred to our neurosurgeon, who started the patient on carbacolin, BD twice weekly, and last I think was that I think the tumor has shrunk significantly in size just from the carbacolin. These are IHS, International Headache Society, criteria for diagnosing headache due to neoplasm. Usually progressive, localized, worse in the morning, and I'm sure you're familiar with all the features, right? I just want to stress that headache occurs in about 40% of patients with brain tumor, and then the classic pattern, right? There's severe, worse in the morning is only seen in about 20% of the patient. In the majority, in a study by Fawcett, 77% actually presented with tension-type headache in the beginning. Some presented with migraine and other types of primary headaches. So the take-home point is that it is not the quality, but the accompanying symptom and sign that suggests brain tumor, because a lot of brain tumor initially present with headache look like tension-type headache or migraine. And neural exam will be normal if it's not too big initially. So I think the headache doesn't improve with the usual prophylaxis and painkillers, right? We should do a scan on the patient, which I'll elaborate more later on.